Good afternoon. Welcome to the webinar. All participants' lines are muted. If you want to unmute yourself, please press *2. You can also use chat box to submit any comments or questions. My name is Jaya Bhargava. I am from IPRO. It is my pleasure to introduce Dr. Priti Patel. Priti Patel, MD, MPH, is a medical officer within the Division of Healthcare Quality Promotion at Centers for Disease Control and Prevention, CDC. She serves as a dialysis activity leader at CDC and is involved with end-stage renal disease networks, state health departments, and many other entities to promote patient safety. Dr. Patel currently leads CDC's prevention, surveillance, and response activities related to dialysis patient safety. She oversees dialysis event surveillance system in NHSN and is a co-founder of CDC's Dialysis Bloodstream Infection Prevention Collaborative. At CDC, Dr. Patel has supervised multiple outbreaks of healthcare-related infections and other adverse events in dialysis centers. She has authored many peer-reviewed journal articles, book chapters, and other scientific publications. She has presented at several meetings to promote patient safety. Today, she is going to give a talk about bugs, drugs, prevention of bloodstream infections in hemodialysis patients. Dr. Patel?
Thank you, Jaya. I'm going to try to speak up, but if we're going through the presentation and and I'm not being loud enough, please just let me know. You can or others can interrupt me or use the chat box to let me know that I'm not speaking loud enough. So good afternoon, everyone. I want to thank Network One for inviting me to give this webinar today. Here are the objectives for the talk today. We're going to go over bloodstream infections in hemodialysis patients, just review what we know about it and some of the basic epidemiology of these events. We're going to go over risk factors for BSI in hemodialysis patients and also describe evidence-based strategies to reduce bloodstream infections associated with hemodialysis. So back in March of 2011, CDC released a report where we attempted to estimate the number of central line associated bloodstream infections or CLABSIs that occurred in different patient populations, and we estimated that there may have been 37,000 estimated CLABSIs in hemodialysis outpatients in the United States in 2008. And that number is pretty comparable to the estimate of all CLABSIs in all hospitalized inpatients throughout the country, which is about 41,000. Now, it's important to note that the estimate here for hemodialysis outpatients is based on very limited data. So, we had a range around this. It's hard to know exactly how many central line associated bloodstream infections occurred in 2008, but that was sort of our best guess. Now we have dialysis centers that are all reporting to NHSN, and so we have a little bit more data. Unfortunately, we have some limitations to that data. So it's possible that the numbers of central line associated bloodstream infections in dialysis patients is going down. So if we use data that was reported to NHSN in 2014, there were about 16,000 estimated CLABSIs reported to NHSN that year. So it's possible, as I mentioned, that this number is decreasing, and it makes sense because there's been national efforts to prevent bloodstream infections in dialysis centers through the ESRD networks and through other initiatives. But we also know that there's a lot of underreporting, or we think there's a lot of underreporting happening to NHSN. So NHSN definitely doesn't capture all bloodstream infections that should be reported to the system. So if there's underreporting rate of anywhere between 60 to 80%, well then that takes our 16,000 number right back up to about 38,000. So it's hard to know whether we're making a difference yet or not, but this is something that we're going to be working on to try to get better estimates of what is actually happening and what is the number. So we don't, unfortunately, have good outcomes data on all bloodstream infections in hemodialysis patients. Most of the studies that have been published have focused on Staph aureus bloodstream infections specifically, and probably most of you know that Staph aureus is a common organism that can cause bloodstream infection, and it's one of the most common organisms to cause bloodstream infections in dialysis patients. So there are a couple of studies that looked at patients who were actually, hemodialysis patients who were actually admitted to the hospital with a Staph aureus bloodstream infection. And most patients who have a Staph aureus BSI should be admitted to the hospital, so it's probably fairly representative. And they found that the average length of stay for these patients was 13 days. The average cost was around $20,000. About a third had complications, and these are things like osteomyelitis, endocarditis, so serious complications. About a fifth had to be readmitted to the hospital after they were discharged. And within 12 weeks, 19% of patients died from any cause of death, and about 11% died specifically due to the Staph aureus infection. So these are pretty serious outcomes. And if you think about what all this means for an individual patient who actually acquired an infection, it's quite impressive, both in terms of prolonged length of stay in the hospital, costly stays in the hospital, high complication rate, high readmission rate, of course, the chance of dying, and other things that we haven't even mentioned, like prolonged course of antibiotics with all of the issues that can have. So these are really serious outcomes, and we want to do whatever we can to try to prevent patients from having these outcomes and these infections. So here's a list of kind of what we think of as traditional risk factors for vascular access infection, including bloodstream infection. And I'm not going to go through all of them. The most important one is really listed at the top, which is the type of vascular access. And I think you all know that catheters have a much higher risk of vascular access infection, including BSI, compared to fistula grafts. But I want to spend a little bit more time today talking about what I think of as the preventable risk factors for bloodstream infection. So number one on the list is, of course, catheter use. If that can be modified, that goes a long way toward protecting the patient from getting these infections. But then there's also inadequate infection prevention and aseptic techniques, both for catheters and other vascular access care. Injection and infusion practices is something I'm going to talk about a little bit today. And then there are other things like dialyzer reuse and buttonhole cannulation, which might also put patients at risk for bloodstream infection. And I'm not going to have time to talk about that today, but I did want these to be on the list so you're thinking about it. So, if you've gotten to the point where you feel like you've really done maximized everything that you can do in terms of maximizing fistula graft use over catheters, reducing your catheters, improving your infection prevention practices, doing everything that CDC recommends in terms of catheter care and vascular access care, and you're still looking for other ways where you can prevent infections, these are two that you should think about as potential risk factors: dialyzer reuse and buttonhole cannulation. So I'm going to spend a little bit of time talking about the pathogenesis and routes of catheter-related infection. So here's a picture of a catheter. It's a purple tube, obviously, that goes through the skin, through the subcutaneous tissue, and then into a blood vessel. And there's two main pathways that we'll sort of talk about of how this catheter can get contaminated and lead to infection. One is an extraluminal pathway, which basically talks about or describes organisms that can be present on the patient's skin, for example, and can get introduced into the bloodstream via the outside of the catheter. So either they track down the outside of that catheter at the time that catheter is inserted, or after the fact, after it's inserted, and it goes down the outside surface of the catheter and into the bloodstream. And then the second pathway is the intraluminal pathway, which basically is the introduction of organisms into the inside of the catheter, usually via the hub of that catheter, and that can be from contaminated healthcare worker hands or through improper aseptic technique used when you're connecting blood lines, let's say, to that catheter, or anything else for that matter, a syringe, dirty gloves, anything that comes into contact with the hub of that catheter and then introduces organisms into the inside of that catheter. Okay, so this is kind of a busy slide showing you sort of that same picture. And there are multiple different routes of infection. Those are the two big categories that I showed you, but there's multiple different ways that organisms can get introduced into the bloodstream and cause a catheter-related infection. I've listed some of the more common ones at the top right-hand side of the slide and less common ones at the bottom right-hand side. So some of the more common ones: contamination during insertion. So you haven't adequately prepped the skin at the time when you're inserting that catheter, and organisms that are on the patient's skin actually get into the bloodstream via the catheter at the time of insertion. The next one is patient skin flora. As I mentioned again, that can happen at the time of insertion, or it can happen later. These dialysis patients can have catheters for really, really long times, and if the external sort of area, the exit site of that catheter is not well maintained, there can be organisms at the site of the catheter that can track down the outside of the catheter and get into the bloodstream. Contamination of the catheter, as we mentioned, is one way that interluminal contamination can occur, and healthcare worker hands is another way that interluminal or extraluminal contamination of that catheter can happen. Some less common ways of introducing infection into the bloodstream are intrinsically contaminated fluid, medication, or device. So intrinsically contaminated means that something's actually contaminated at the point of manufacture. So when a device like a catheter is manufactured at the company, the plant, or when a fluid is or medication is actually manufactured at the plant and packaged. That happens, it can happen, but it happens very infrequently. And then hemodialysis spread, which just basically means spread from a distant source of infection, is another possible mode of a catheter-associated infection that happens less commonly, we think, than some of these other modes. So, what's the primary pathway of contamination? This is something that people have debated for a while, and there's a conventional wisdom on this. And the conventional wisdom has been that for short-term catheters, such as in hospitalized ICU patients, that the extraluminal pathway is the primary mode, whereas in longer-term catheters, such as in hemodialysis patients or tunnel catheters, that the interluminal pathway is more of the primary route. And to some extent, this conventional wisdom has been based on this study that was published back in 1993. That was actually a very small study of non-tunnel catheters in cancer patients, where they took a look at colonization and biofilm of a small subset of catheters that were part of this study. And they found that among catheters that were in place for more than 30 days, so these are what we would consider sort of a longer-term catheter, that the colonization and biofilm on these catheters was mostly intraluminal on the inside of the catheter, whereas for catheters that were in place for a shorter number of days, less than 10 days, the outer surface predominated in terms of the amount of colonization and bacterial biofilm. So this was just one piece of information that sort of helped support this conventional wisdom that it's the interluminal pathway that's most important for longer-term catheters and the extraluminal pathway that's more important for shorter-term catheters. But then there was a study that was published in AJKD in 2012, and this study actually looked at hemodialysis catheters. So they collected tunnel catheters that had been removed from 76 hemodialysis patients over a 3-year period. 26 of those patients had bacteremia. 50 of them had catheter removal for other reasons, non-infectious reasons. And they excluded patients who had exit site infection. And what they did was they cultured and measured the biofilm on different surfaces, or several different surfaces of the catheter, and I tried to sort of show that schematically here on the side. So there's what I'll call an intravascular segment, which is the part of the catheter that's inside the vessel. There's the extravascular segment, which is a part of the catheter that is outside of the vessel, but still not outside of the skin. And there's an outer surface, which is just the outside of the catheter, and a luminal surface, which is the inside of the catheter. So what they found that was that the catheters were culture positive in 62% of bacteremic patients and 30% of uninfected patients. So there's two things that are interesting here. Not surprisingly, more patients who had bacteremia were likely to have a culture positive catheter. Again, that makes sense. But there's still a large proportion of uninfected patients who have culture positive catheters. So it doesn't take much for a catheter to get colonized, right, with bacteria, even if the patient doesn't have clinical signs of infection. So this is another testament to the fact that why catheters are considered so high risk. So interestingly, the most common site of bacterial growth in all of these patients was the outer surface extravascular segment. I'm just going to say that again. The outer surface of the catheter, outside surface of the catheter, and the extravascular segment, the piece that's outside of the vessel. So they found significantly thicker catheter biofilm in bacteremic patients, all surfaces. Again, that makes sense. So if you're more likely to have a bacteremia, you're more likely to have a thick catheter biofilm. They found thicker catheter biofilm on the outer versus the luminal surfaces in both patient groups, in both segments, and the extravascular as opposed to the intravascular segment in both patient groups and both surfaces. And I'll show you my attempt to sort of depict this graphically, which I think is a little bit easier to digest. But interestingly, the duration of the catheter, so how long the catheters were in place, had no impact on the rate or location of the bacterial growth. So unlike what that Rod study found that was published in 1993, here there was no difference based on how long the catheter had been in place, whether there was more biofilm or culture positivity in one surface of the catheter versus another. So here's the picture of what I think they're describing in their results, that there was more biofilm on the outer surface versus the luminal surface of the catheter, and more biofilm on the extravascular surface versus the intravascular surface of the catheter. So this kind of suggests that there's potentially more of a role of the extraluminal pathway in these catheters than we had originally thought. So it's hard to make any sort of conclusions just based on these studies of where is their biofilm and where are catheters more likely to be culture positive, but it does help to sort of, I think, reframe the conversation about what is the most common pathway. This is our list of 9 recommended interventions for dialysis bloodstream infection prevention that we recommend that all dialysis centers use to prevent BSIs. Hopefully you guys have seen this before. I'm going to run through them quickly in a couple minutes, but I just wanted to point out, since we're talking about these different pathways, that we recommend interventions to address those pathways. So we recommend catheter hub disinfection, or what we call scrub the hub, which attempts to address that intraluminal pathway. And then there's also recommendations such as use of antimicrobial ointments or povidone iodine ointment at the catheter exit site, and also an alcohol-based chlorhexidine for exit site antisepsis, which tries to address that extraluminal pathway. So there still may be some questions about whether those latter interventions that address the extraluminal pathway are effective or worth pursuing in this population, and I'm going to show you some studies to try to get at that. So just some basic information about chlorhexidine, which is the antiseptic that we recommend for use at the catheter exit site for exit site care. Obviously, the purpose of any antiseptic, whether it's chlorhexidine or something else, or the idea behind it is that cleansing the skin decreases colonization, and so that should decrease the organism burden around that catheter that could be introduced by the extraluminal pathway. Chlorhexidine has a rapid and persistent antimicrobial activity, and by comparison, povidone iodine has to be applied for 2 to 3 minutes and allowed to dry for its fullest effect. Chlorhexidine is part of the central line bundle, so for all central line insertions, it's part of the best practices and recommended practices to prevent central line associated bloodstream infections, and it's recommended by HICPAC, which is the Healthcare Infection Control Practices Advisory Committee, and CDC and KWP. And that's specifically, again, for catheter exit site care. So this is some data from a meta-analysis that was published in the Annals of Internal Medicine back in 2002, and it was a meta-analysis looking at studies of chlorhexidine versus povidone iodine for catheter exit site care. There were 8 randomized controlled trials that were included. They were all done in hospitals, either focused on ICUs alone or hospital wards plus ICUs. There were more than 4,100 catheters altogether in all of these studies. And you can see a list here of the different kinds of catheters that were included. They did include hemodialysis catheters, although that was not the focus of these studies or the meta-analysis. Now, the mean duration of the CBCs in these studies, the process studies, was 1.6 to 10 days. So you can see that it was still relatively on the shorter side. And the outcomes that they looked at were catheter colonization and catheter-related bloodstream infection. So here's kind of the summarized results, and I'll walk you through this. You see on that figure that there are a bunch of boxes. So you see all the different studies that they incorporated into this meta-analysis are listed. Each one of them has a box next to it. And there's a vertical line. The vertical line essentially means that there's no difference between chlorhexidine and povidone-iodine in terms of its ability to prevent catheter-related bloodstream infection. If a box is on the left side of that line, then it means that chlorhexidine was better than povidone-iodine at preventing BSIs. And you'll see that for almost all of these studies, the box is, in fact, on the left-hand side of that vertical line. If you look all the way at the bottom of that figure, you see a diamond-shaped figure that basically summarizes all of the data from those individual studies. And that diamond is sitting to the left of the line. So that means that when you combine all of that data from all these studies, there is in fact a protective effect of using chlorhexidine relative to povidone-iodine for catheter-related bloodstream infection. And you see that the relative risk is about 0.5, which means that using chlorhexidine reduced the catheter-related bloodstream infection rate in half compared to povidone-iodine. So again, this is one piece of information, or based on a lot of well-done studies, randomized controlled trials, that demonstrates why chlorhexidine is preferentially recommended by CDC and KWP for use at the catheter exit site. So again, just to summarize, they concluded that there is a significant reduction in CRBSI and catheter colonization associated with chlorhexidine use. There was no heterogeneity or evidence of publication bias, which can skew the results. And they found that this meta-analysis, or these results, were generalizable to various hospital patient populations, not necessarily to patients with catheters that are in longer than 10 days. And so that's one challenge with thinking that all of these studies automatically apply to hemodialysis patients, but nonetheless, I think it's convincing evidence about chlorhexidine and tells us something about the strength of evidence supporting this product. So there are very few, unfortunately, studies done specifically in hemodialysis patients. This is one of them. This was an observational study that compared 2% chlorhexidine with alcohol versus 10% povidone-iodine. And it wasn't designed exactly how I would have liked it to be to answer this specific question, but nonetheless, it's one of the few studies that are out there that looked at chlorhexidine use in dialysis patients. So this was a single pediatric hemodialysis center. It involved more than 20,000 tunneled hemodialysis catheter days, and the main outcome was catheter-related BSI. So you can see here that they had two intervention periods. In period 1, they used 10% povidone-iodine at the catheter exit site, along with a biopatch, which is a chlorhexidine-impregnated sponge, and they soaked the catheter hubs in povidone-iodine. In period 2, those same patients had 2% chlorhexidine with alcohol at the exit site, with still the biopatch, and then they cleansed those catheter hubs with chlorhexidine instead of soaking them in povidone-iodine. So the difference here between the two intervention periods is that there is chlorhexidine plus alcohol at the exit site in period 2 compared to povidone-iodine, and they scrubbed the hubs with chlorhexidine in period 2 as opposed to soaking them in povidone-iodine. And in both intervention periods, biopatch was in place. So that's the part that's a little bit difficult to sort out because biopatch was there in both groups. But what they found was that there was a rate reduction of 50% in the chlorhexidine group that was statistically significant. The chlorhexidine group also had significantly fewer hospital days for CRBSI, and they concluded that chlorhexidine for exit site and hub care were more effective than povidone-iodine, and they emphasized the role of catheter hub care. This is another study that I just wanted to mention that was published in the American Journal of Infection Control in 2013. And in this study, they basically assessed and compared the antiseptic efficacy and substantive effect, which I'll explain in a second, of 2% chlorhexidine with alcohol, 10% sodium hypochlorite, and 10% povidone-iodine. And one of the reasons that I'm mentioning this study is because sodium hypochlorite is something that is used in a lot of dialysis centers. So the outcomes that they looked at, and this was a study basically of they examined the skin on healthy volunteers. So this was not a study of patient outcomes, but they basically applied these antiseptics to the skin of volunteers, and then they tested the bacterial colony counts on those areas of skin at 1 minute, and then also the ability to inhibit newly introduced bacteria at 2 hours. So the latter part, how did they do that? They basically, obviously, they would culture the bacterial culture to determine the bacterial colony counts at 1 minute, and then after 2 hours, they would take a finger, let's say, of a volunteer's hand that had had one of these anesthetics applied to it, and they would plate that finger onto a bacterial-infused agar plate and determine what happened on that actual agar plate at 2 hours. So on the chlorhexidine finger, so on the skin where chlorhexidine was applied, not only were there fewer they had the same sort of effect at 1 minute, so it's able to inhibit bacteria at 1 minute, but also at 2 hours there was actually a zone of inhibition on the bacterial agar plate. So they concluded that the three agents essentially have the same effect at 1 minute, but only chlorhexidine has a substantive effect where it can actually inhibit newly introduced bacteria for a period of hours after its application. So that's one of the unique properties of chlorhexidine compared to these other anesthetics, and again helps explain why it's preferentially recommended for use at the catheter exit site. Okay, so now I'm going to switch gears and show you some of the best data that we have supporting use of antimicrobial ointment at the catheter exit site. This was a really well-done study that was published in JASN in 2003. This was a randomized, double-blinded trial of polysporin triple ointment. It was specifically in hemodialysis patients, so there were 162 adult HD patients with cupped tunnel internal jugular catheters, and you can see the outcomes are summarized in this table. The polysporin triple group, so this is a group that got polysporin triple ointment at their catheter exit site every time they had a dressing change with each dialysis treatment, and they had significantly lower infection rate, and by infection that means all vascular access associated infections, including local access site infection and bloodstream infection. They had lower bloodstream infection rates. They had fewer deaths, fewer hospitalizations, and fewer catheter removals due to infection. So use of ointment at the catheter exit site significantly reduced bloodstream infections, local access site infections, and improved survival in this study. And the number needed to treat, which is this last bullet at the bottom of the slide, for all infections was 5, and for bloodstream infection was 7. So you only had to apply antimicrobial ointment to the catheter exit site for 7 patients to prevent 1 bloodstream infection, which is pretty impressive. So these are this is really strong study with impressive, well-designed study with impressive results, and is one of the reasons why antimicrobial ointment is recommended at the catheter exit site with every treatment. In the interest of time, I'm going to skip over this other study, these other studies which kind of address chlorhexidine sponge dressings. And I'm going to move on to our recommended interventions and some of our practical evidence. So probably all of you have heard of this by now. In 2009, we initiated a dialysis BSI prevention collaborative, and our goal was to demonstrate preventability of BSIs among hemodialysis patients, and we wanted to do this through increased adherence to existing recommendations. So we weren't going to come up with any sort of novel technology. We just wanted to see if you took existing recommendations and actually got people to do them all the time, could you have an impact on bloodstream infections. We asked facilities that were participating to measure their infection rates using NHSN, so this was prior to the ESRD QUIP rule. And we developed an intervention package and implemented that, and that was based on CDC and HICPAC recommendations, and the focus was on catheter maintenance practices. So I wanted, as I mentioned before, I wanted to just briefly run through our recommended interventions. The first is performing surveillance and feedback using NHSN. So not just measuring BSI and other dialysis events using NHSN, but actively sharing rates and information from NHSN with frontline staff so they know what the rates are. Number 2 is performing monthly hand hygiene audits and, again, giving feedback of the results of those audits to staff. Number 3 is doing observations of vascular access care and catheter care, at least quarterly, and then sharing that information with clinical staff so they know how they're doing. Number 4 is staff education and competency, so not just training staff on infection control topics such as access care and aseptic technique, but also performing competency evaluations to make sure that staff who are doing catheter care are competent to do that, and staff who do other vascular access care have the right skills and ability to do that. Number 5 is patient education and engagement, so not just providing standardized education for patients on infection prevention topics, but also involving them in infection prevention in the unit. Number 6 is catheter reduction, which is obviously critically important. As we mentioned, this is the greatest risk factor for vascular access infections, including bloodstream infections. So anything that can be done to move patients away from catheters and get them on a safer, more permanent vascular access type is well worth the effort. Number 7, we've been talking about a lot, which is using an alcohol-based chlorhexidine solution for skin antisepsis for central line insertion and during dressing changes at the exit site. So we haven't talked so much about central line insertion, but that's something that is recommended. And then, of course, also doing this for exit site care during dressing changes. Next is catheter hub disinfection. So scrubbing catheter hubs with an appropriate antiseptic after the cap is removed and before accessing. And I'm going to show you a slide with that in just a second. Okay, so scrub the hub is what we call this, and the basic idea is that if you're a facility that uses bed end caps to cover the catheter hub, that hub should be scrubbed with antiseptic after removing the cap and before connecting to blood lines. And you're going to do the same thing during disconnection before attaching new caps. So if you're just soaking or wiping the hub with the cap still attached, in other words, you have a cap at the end of the catheter, and you're either soaking that hub with the cap on or wiping the hub with the cap still on, all you're doing is basically cleaning the outside of the cap that you're just going to then discard. And it doesn't effectively address that intraluminal pathway that we talked about, right? You want to ultimately get at the junk and remove organisms that are on the surface of that hub that could be introduced into the patient's bloodstream. So for more information on this, if this is something you're not yet doing, take a look at our Scrub the Hub protocol that's on our website. Part 2 of this is for facilities that use closed connector devices, the needleless closed connector devices. You're going to follow a process that's basically the same as what I just described when you're changing your connectors. And in between changes, you're going to obviously scrub that access port with antiseptic before you access it, just like you would any other injection port. And for all facilities, we suggest using a sterile antiseptic pad to do scrub the hub. There are actually antiseptic pads out there, including alcohol pads, that are not sterile. So it's worth just taking a look at the pads that you use to make sure it's sterile. And then the last intervention that's on our list that we talked about a little bit, or we talked about a little bit of evidence to support it, which is the use of antimicrobial ointment. And we recommend applying antibiotic ointment or povidone iodine ointment to the catheter exit site during dressing change. And for more details on that, you can just take a look at our website. So we asked these in our collaborative, we asked facilities to implement these interventions, and we took a look at what impact it had. And while it was hard to quantify exactly how many facilities were part of this collaborative and who was participating, we focused on those facilities that had reported the most consistent amount of data and for whom we had a good idea that they were actually participating in this collaborative. So we reported out results from 17 facilities, again, that had consistently reported data throughout this time period. And what we found is that if you look at sort of the solid black line, you see that there's what we call the pre-intervention period. So baseline period went from about January 2009 to January 2010. And the rates there are pretty stable or maybe increasing a little bit. And we saw a 54% decrease in access-related bloodstream infections. This is using NHSN definitions around the time of the intervention implementation. And at least for this initial study period, when we looked at the post-intervention period, or I guess what I'll call the early post-intervention period, those rates appeared to remain low. So facilities were able to reduce their rates and were able to sort of keep them low for this period of time from 2010 to March of 2011. And what I'm not showing you here is that we also had data demonstrating that almost every single facility saw an individual difference, an individual reduction in their individual facility rates. So initially we saw a relatively rapid reduction in rates around the time when facilities implemented these interventions. They saw individual facility level improvements, and some of the limitations of this study were that it was an observational study. We didn't have as much pre-intervention data as we would have liked to do the analysis. Our facilities were intentionally selected as being highly motivated. We had more hospital-based facilities than would exist in the general population, and so it's questionable how generalizable this study was. And we didn't have enough data to be able to model vascular access specific rates, so to look at specifically what was happening among catheter patients versus fistula and graft patients. And the reason that I listed out some of these limitations is not to slam our own study, but really to set us up for this next study, which is a Fresenius catheter care study that was published in AJKD in 2014 that really, I think, addressed all of those limitations and concerns that people might have had with our studies. So they implemented and assessed CDC-recommended catheter care practices, and these were the two that they focused on. Number one is use of 2% chlorhexidine with alcohol for exit site care, and number two is use of alcohol for scrubbing the hub at initiation, termination, and any time dialysis lines are disconnected. So again, they're doing chlorhexidine at the exit site and scrub the hub are the two interventions that they focused on. They studied this in 211 intervention group facilities that were matched to 211 facilities that continued their usual care. There was a 3-month baseline period. They trained facilities over a period of 1 month, and then there was a 3-month follow-up period. And what they found was 22% reduction in catheter-associated bloodstream infection rates at 3 months and a 41% reduction at 1 year. They also found a 21% reduction in IV antibiotic starts at 3 years, at 3 months, and a 27% reduction in hospitalizations due to sepsis at 1 year. So these were statistically significant reductions. They happened relatively rapidly, just like we found. And they also found reductions in related meaningful outcomes, right? So if you're able to reduce not just your infection rate, but your antibiotic usage rate and your hospitalizations due to sepsis, those are meaningful outcomes that matter to patients. So last thing I'll say about this is, again, this was a large study, a randomized cluster randomized matched controlled trial that was done in large dialysis organization facilities, so your typical outpatient dialysis centers. No generalizability issues here. I think if these facilities were able to see a reduction, then any facility should be able to. So this slide shows results from a paper that we just recently published that was a follow-up to our initial collaborative study. So here we were looking at, were these reductions that facilities saw in the first 15 months after implementing these interventions sustained over time? So we examined trends in the time periods and changes in the trends. Our baseline period was still the same. It was still the 1 year prior to the intervention implementation. We called this early implementation or early intervention period, the period that was studied in the original study, which is the first 15 months after the intervention. And then we also looked at a late intervention period, which went all the way up to 48 months. So we're talking about 4 years after the interventions were implemented. And we found there was a reduction in the BSI and access-related BSI rates when you compare the baseline period to the intervention period. So overall, facilities dropped, just like we saw in the initial study that we did. The access-related BSI rates, when we did the model, those rates dropped by 44% overall, and this time we had more data, so we could actually separate it out into the catheter group and the fistula graft group. So we saw a reduction in AR-BSI of 49% in the catheter group around the start of the intervention period. We didn't find a significant reduction in the fistula or graft group, so that's interesting to know. There were no, when we looked out at the what happened in these in the trajectory of the rates over time, there was no increase in the rates in the early intervention period or in the late intervention period. And we did actually in the catheter group see reductions over time in that slope of the bloodstream infection and access-related bloodstream infection rates. in the late intervention period. So if anything, it looked like things were going down. They were not going back up, which I think is really good news, because it's always, it's sometimes easy to show a difference. It's a lot harder sometimes to show that the difference can last. So to sum this part up, the CDC Collaborative was a small demonstration project. We were able to show a 54% reduction in access-related bloodstream infections, individual facility-level impact, and data showing sustainability 4 years out from the initial intervention implementation. The Fresenius study was a large randomized trial conducted in large dialysis organization facilities. They showed a 22% reduction in their catheter bloodstream infection rates at 3 months and a 41% reduction at 1 year. They also found reductions in important outcomes that are related to infection, and I think overcomes many of the criticisms or concerns regarding our CDC Collaborative study and whether or not it's a real difference and whether it's generalizable. So bloodstream infections, I think these studies really show that these infections in dialysis patients are preventable. The impact thus far appears to be among patients with catheters. So remember I told you, this was very quickly that I went over it, but the difference that we saw for the most part was in the catheter group, and we didn't see any significant reduction or difference at all in the rates in the fistula graft group. And of course the Fresenius study really just focused on catheter patients, so we don't know anything about what happened with their fistula graft patients. But it shows that improved infection rates can occur relatively rapidly, which occurred in both of those studies, the Fresenius one and the Collaborative, and can be sustained for a prolonged time period. And there's also likely to be secondary benefits of those infection reductions. So a couple of thoughts about this. BSIs are preventable. There's a lot you can do. If you're not doing these things yet, this is a great time to get on board. There's lots of tools and resources available and support from the network and others. Catheter care is likely to be the highest impact and where you might want to focus your efforts unless you really have a good reason to focus them elsewhere. And it's also important to engage all staff as much as possible, involve them in assessments of practice and coming up with ways to improve, because at least in our experience we found that that's been very helpful. There's a whole host of CDC resources that are available, checklists, audit tools, patient pocket guides, posters, things that are on our website that you can order for free. So if any of these are things that would be helpful for you, take a look at our website. There's also this best practices video that I hope you all have seen. If you haven't, it's only 11 minutes long, and I highly suggest it because it puts all of this information together and shows you how some of these basic procedures like hand hygiene and catheter care should look if they're being done right. So there's 5 segments. It's available on our website, on YouTube, and you can also get it on DVD if you want. So every time I give this talk, I always have some facilities to say, we're doing all these things. What else can we do? What else can we do? So a couple of other things that I wanted to mention. Take a look at your antiseptic practices. If you're doing everything that CDC recommends, some things that we suggest in addition are that single-use applicators of antiseptic are better than multi-dose bottles. Multi-dose bottles can actually become contaminated and have led to outbreaks in the past. The antiseptic ideally should contain alcohol, so we recommend chlorhexidine with alcohol, or povidone-iodine with alcohol. And you should use an appropriately sized antiseptic applicator to achieve wet contact of the area. So if you're using a small little 2x2 antiseptic pad to apply antiseptic to a patient's arm before you cannulate their fistula graft, pay attention to whether that's really getting the entire area. If it's not, then you need to use a larger antiseptic applicator or more antiseptic. And then again, as I mentioned before, if you're using antiseptic pads, take a look and make sure that those are sterile pads and not non-sterile. Injection safety is the next thing we're going to talk about really quickly. So going back to these whole pathways of introducing organisms into the bloodstream, right? It's important to note that contaminated medications are infusate. So now we're talking about injectable medications, saline, heparin, anything else that gets infused through the dialysis circuit, for example. Poor aseptic technique when accessing those injection ports or contamination of those medications or infusates can cause organisms to enter the bloodstream. And this is true whether we're talking about a catheterized patient or a patient with a fistula graft, because ultimately, no matter what kind of vascular access you have, you are connected to a catheter for the hemodialysis process, and that opens you up to introduction of organisms from anywhere in the circuit if something's contaminated that's being infused into the circuit. So I'm going to talk about a couple of medication strategies and sort of the safety continuum. There's lots of different ways to handle medications in a dialysis center, and some ways are safer than the others. So on this particular continuum, we see that on the left-hand side are some safer strategies. So using manufactured pre-filled syringes of medication or saline, or medication from a single dose vial for a single patient, or a single multi-dose vial for a single patient, gives you less opportunity for contamination. So these are safer strategies. On the opposite extreme, you can also use a multi-dose vial of medication for more than one patient. But what that means is that you have to be more rigorous about how you prepare these medications, where you prepare them. It requires proper storage and proper handling between uses to make sure that that medication vial does not become contaminated and then affect multiple individuals. So again, you can do it either way. The options on the left-hand side of the slide are generally safer. Now, in terms of where you prepare injectable medications, the safest would be to do medication preparation in a clean room that is completely physically separated from the treatment area. That's the safest option, so that no environmental contaminants can contaminate your medications that are then injected into a patient's bloodstream. On the right-hand side, you can also do medication preparation in the patient treatment area, not at the patient station, but somewhere within the patient treatment area. But it's very difficult, in my opinion, to find a clean space within the patient, a truly clean space within the treatment area that's not going to be at risk of some sort of contamination, direct or indirect. Okay, so again, that's just to give you an idea of some of the things that you can think about to make your medication practices safer. So one commonly encountered error is saline withdrawn from the bag at the dialysis station for flush. So here what we're talking about is the tech or nurses draw syringes of saline from the saline bag at a patient station to use them for flush. It's important to note that the saline bag is single-use and should not be re-entered even if it's for the same patient. And the patient treatment station is a contaminated area and it's not suitable for medication prep. So in general, the routine practice should be to prepare your medications someplace other than the treatment area, and definitely not at the patient treatment station. Again, as I mentioned, ideally in a separate room, but the treatment station is not appropriate for medication prep. So here's a checklist that we have for hemodialysis injectable medication preparation. I'm not going to go through all the steps, but I'll give you some of the highlights. The first thing is that we want to make sure that the medication preparation area is clean. And as I mentioned, this is really difficult to do in dialysis centers. It can be difficult to do. A clean room is always preferred to an area within the treatment floor. So take a look at what options you have. Some facilities, I know every facility doesn't have extra rooms, but some facilities have clean supply rooms or extra rooms that are being used for something else. And could be an area where you could actually make it a clean room and use it for medication prep. So regardless where you do your med prep, it has to be an area that is designated for medication preparation, and it has to be free of contamination sources, and we've listed what those are here. So that includes blood, body fluids, contaminated supplies, tap water, dialysate, etc. And there are a couple of other things in here that explain, how to make sure that your vials, medication vials, are handled appropriately afterwards. So you're going to discard single-dose vials and store properly your multi-dose vials. This is a checklist that goes over hemodialysis injectable medication administration. So first and foremost, you want to transport the medications from the medication prep area to the place where you're going to deliver those medications directly. And you want to use aseptic technique for scrubbing that injection port with antiseptic prior to injecting and also attaching the syringe and administering the medication aseptically. Like all of our other checklists, we have audit tools to accompany those checklists. You can use these audit tools to assess staff in your facility to see how they're doing with their injectable medication preparation and injectable medication administration. And these are things that you can track in NHSN if you would like to. So I'm just going to go over two quick questions to review what we talked about before I conclude. The first one is, which of the following represents a common intraluminal pathway of catheter contamination that can cause bloodstream infection? And the keywords here are common and intraluminal pathway. Okay? So choice A is skin contaminants introduced during catheter insertion. B is contamination of the catheter hub from healthcare worker hands. C is hematogenous spread. And D is intrinsically contaminated device or infusate. And the answer to this question is B, contamination of the catheter hub from healthcare worker hands. So A, skin contaminants introduced during catheter insertion is an extraluminal pathway. B is an intraluminal pathway contamination that we think occurs commonly. C, hematogenous spread is neither intraluminal nor extraluminal. And D, intrinsically contaminated device or infusate can be intraluminal, but is not thought to occur very commonly. This is typically pretty rare. So again, the answer to this one is B. And then the second and last question, based on available evidence, which of the following interventions is likely to have the greatest impact on reducing bloodstream infections in hemodialysis patients? A, catheter care practices, such as performing scrub to the hub. B, consistently washing the AV fistula or graft site with soap and water prior to cannulation. C, patient self-cannulation of fistula or graft. And the answer here is A, which is catheter care practices. So thus far, the best evidence we have suggests that you can make an impact on bloodstream infections by focusing on improving catheter care practices. While we also had some interventions in the collaborative focus on fistula and graft care, we did not see any difference or reduction in those rates, and it's probably because the rates are low to begin with in that group. So infection rates are low in fistula and graft patients, and so it's hard to make it go even lower. So choice B is possible that there may be benefits in terms of reducing infections or engaging patients in their care, but we haven't seen any evidence to support that washing fistula and grafts is a way to actually prevent infections. And then choice C doesn't have any evidence surrounding it, to my knowledge, that would suggest that it's a way to reduce infections. So that's all I have. I guess we have a few minutes potentially for questions, and I just want to thank you all for attending and for the things you do every day to keep patients safe from infection.
Thank you very much, Priti, for your presentation. I just unmuted all participants. If anybody have any questions?
That's Robin. Priti, I have two questions it was regarding the betadine, like the application of 2 to 3 minutes, and that's what the literature says. And I know from doing this, I'm repeating on my own phone. I don't know if I should
Yes. Hold on one second. Let me. Sure. Please unmute yourself, Robin, by pressing *2. Can you press that better? Yes, thank you.
So, I feel like it's kind of a silly question to ask you, but that's what I teach, like 2 to 3 minutes of application time, and whether you're prepping a site or doing catheter care, it's a long time to prep a site, 2 to 3 minutes, one site at a time. I'm wondering, like, do people really adhere to it? Should it be even a recommendation? Like, I don't know. I mean, that's what I teach, but it's people are always questioning me about that 2 to 3 minute application time for betadine. We don't use it. We don't like to use betadine unless we have to. We use chloroprep. But there are still some facilities using that. That was my first question or comment. And then my second one, I hope we were one of your people, because it's what really made me a true believer, but we had a spike of infections. I think it was 2011, like 13 infections, catheter infections. We had hired 5 new staff members, and like over that course of 2 or 3 months, we just surged. And I did a ton of work, and we went with implementing all of the, the CDC recommendations and the DSI work, and it worked, and it has sustained. But one of the things that we kept to kind of double barrel, but I don't, is we do a betadine soak before we do anything. And the reason why we did it at the beginning is because we had a handful of patients that had promiscuous activity and were either homeless or did recreational drugs, and we weren't sure, we felt the outside of the catheters were dirty, so we did that. We do a 5-minute betadine soak, let it dry, and then we do scrub the hub. I've seen a couple of articles, like I'm hesitant to take it away because we haven't had any infections, but it doesn't really do it doesn't have any evidence that it does any good. Is that what you're saying again in this presentation today?
Priti, you may have to unmute yourself by pressing *2 again.
Okay, thank you for reminding me to do that. So, thanks for your comments, Robin. I think, one of the things that, you're absolutely right, one of the things that I was trying to communicate is that there are some facilities out there that are just soaking the caps. And if you are just cleaning the outside of that cap that immediately gets discarded, then you're not effectively addressing that intraluminal pathway of contamination. So if you're doing both, if you're, cleaning the outside of that cap, you then discard it, and then you're also scrubbing the hub underneath the cap, that's fine. So I don't know, it sounds like that's what you're doing, and you're reluctant to sort of give up the soaking of the cap piece.
Yes. Yes, I am, although I am, because it's not broken, why fix it? Like, we've had no infections. But we do both, and the staff isn't happy about it, but it works.
So, in our Scrub the Hub protocol, I would have to actually go back and look at it, but it does say that it's okay to clean those caps before you discard them if you want to. So, if that's what your facility is sort of doing and you're comfortable with that, it's okay to keep doing that as long as you scrub the hub under the cap as well.
We have beautiful site scrubs. They're like Cadillac cleaners. They're awesome.
Yeah, one thing I will say, which connects to sort of your first comment about how povidone iodine is used, is that I'm not sure that soaking something in povidone iodine has the same effect as, applying, like cleaning something or disinfecting something by applying povidone iodine. So I don't know how effective the soaking is. And again, this is something that hasn't ever really been studied as an individual intervention. So you might consider maybe, wiping those caps or, you know what I mean, like wiping them with disinfectant before removing them as opposed to doing the soap. Because I'm not sure.
I can look into that.
How valuable that is. And I'll look at our protocol and see exactly what it says. It does allow for cleaning the caps, but I think we're trying to get away from the soap because I'm not sure that the soap really achieves disinfection like you're trying to.
Yeah, with friction and
I'm looking at the time, and we have the polling on, and we have about 2 minutes left for the polling to close. So I want to ask if anybody else has questions, please send them to us, Jenna Warner or Acacia Finlayson, our coordinators, quality improvement coordinators. We'll be in touch with you. And Priti, thank you very much for your presentation. It is very informative, and it has very convincing data to support CDC recommendations. If you have any questions, again, please send them to Jenna. I think I'm going to ask you all to please respond to the polling questions. Thank you very much for attending this webinar.
Thank you, Jaya.
Thank you, Priti. Thank you, Robin.
thank you.